Hello, everyone. I'm Sonia Del Tredici.
I'm Dr. John Keenan.
We're super excited to be here. Thank you so much for inviting us to this conference. So before we get started on the material, we wanted to just introduce ourselves a little bit. And I'm going to start. So my name is Sonia Del Tredici. I'm a primary care general internist. We work in South Central Pennsylvania in sort of a relatively rural area. Give me a second to bring my speaker notes up here. And the reason that I got interested in addiction, I've always been interested in the mind-body connection in medicine, but I had a personal friend who was suffering from opioid use disorder, from heroin addiction back in the day. And that friend, without sharing too many details, but that friend went to their doctor and asked for help. And that family doctor, this was an era where buprenorphine was less available, that family doctor went home, said, yes, I will help you, did the 8-hour buprenorphine training, which was required at that time, came back to work the next week with an emergency DEAX certificate, prescribed buprenorphine for my friend for the first time. The medication worked great, and I was really happy about that. But I also heard about this, and I said, I want to be that doctor. Someone comes to you for help, and you go above and beyond, and you can help them. And that's what inspired me to do my buprenorphine training and start working with patients with opioid use disorder. The other thing that really inspired me is I finished my training and started my first, kind of professional attending job in 2007, 2008. And that's the height of medical opioid prescribing when doctors were giving out a ton of opioids. So I inherited a large number of patients taking high-dose opioids. I saw them doing very poorly. I saw many of them descend into addiction. And I really felt like since we as doctors had caused this problem, it was up to us. It was our moral responsibility to actually help people get out of that. A little bit, kind of a joke, you break it, you bought it. I kind of don't like saying that about people, but it was kind of true. Like, we caused the problem, it's our moral responsibility to fix the problem. So those are the reasons I got interested in addiction medicine.
Yeah, my name's John Keenan. So I actually did my training just down the road in Lynchburg, Virginia for family medicine. And there I got really good training in management of chronic opioids for pain. Although I'll be honest, I had little to zero training in substance use disorder. My experience at that time frame when I graduated residency was a handful of really what I would kind of honestly say is antagonistic interactions with patients with active substance use. It wasn't something that I had good training in. I moved to South Central PA, very different community. We really were struggling with opioid crisis at the time frame. The health department, the year I started practice, we had 150 some deaths from opioids in my community. That's just shy of one person dying every other day. And it was triple the rate of breast cancer deaths in my community at the time. So I kind of evolved into this almost out of a need in the community. And I was really lucky at the time because the institution I worked for was very supportive. They invested some financial resources to get me some additional training. I had a bunch of really good mentors. Dr. Del Tredici was actually an early mentor of mine, so I actually kind of like grew up to be like from the kid to like an adult kind of practicing with you. And over time, my practice has evolved not only for substance use disorder, but I treat comorbidities, so I do pharmacogenomics, hepatitis C treatment, HIV treatment, and I kind of really spend a lot of time with the vulnerable population of our county, and I love the work. It's incredibly rewarding, and that's what got me into this.
And then, like Tom said, we have this podcast, Addiction Medicine Journal Club. So my cousin, who's another doctor, a gynecologist, she says, if you have a lot to say that no one wants to hear, start a podcast. And so we love talking about addiction medicine research, and we may have worn out our welcome among everybody we know. And so we have this podcast so we can share our love of addiction medicine research beyond our local community in Pennsylvania. So with that introduction, we're going to get started talking about treatments for addiction.
So I guess first thing, what's better, medical or behavioral health treatment for substance use disorder? I'm sure a lot of people in this room feel one way or another about that concept. There's really not a clear answer, to be honest with you. Addiction's complex. It's influenced by genetics, physical health, mental health, life circumstance. And just to kind of dig a little bit into them, the current understanding is that about 50% of substance use disorder can be attributed to a handful of genes that are either protective or increase your chances of actually developing substance use disorder. I'm not advocating for this, but just to let you know how refined this is, there's a test now available called the ADVERT-D, and you can actually test someone before surgery if they have some of these genes that predispose them to substance use disorder. And it's kind of an inference from an inference, but we're kind of refined to that level. like I said, I don't know how you use that test without bias, but we are available that, we do know that there are genes related to this. Physical health and mental health, it's like this hamster wheel, the one feeds the other into chronic pain. Chronic pain and chronic opioid prescribing is a big issue in the United States, and it was even more of an issue before. About 10% of patients, up to 20% that are prescribed chronic opioids for pain will develop a substance use disorder. And there's data that 50% will at some point misuse the medication. So physical health, mental health, it really drives this problem. The last thing is just life circumstances. Anyone here that works in recovery community has probably left a room with a couple tears in their eyes just hearing a very, very sad story. Bias plays a humongous role here in terms of treatment outcomes, but also how we treat patients and what treatments they seek. And actually, I think the question itself isn't only complicated, but it's probably not the right question because it assumes there's a single right answer, and I don't think that that's the case. The longer I'm a physician, the more gray I see the world in because there's never kind of a black or white scenario. And I tell people, I'm like, this isn't how it's supposed to be, but you might prove me wrong. A little bit about the key bias drivers here. So this is kind of my biggest bugaboo in terms of recovery community. It's like, if it worked for me, it should work for you. So people that recovered one way kind of imposing a view upon someone else that this is how they should also recover. There's selection bias. It's probably not surprising that doctors tend to kind of go more medication-centric, therapists and counselors tend to lean towards behavioral health. But I think we often forget that actually patients have their own bias in terms of selection of treatment, right? Where they present for treatment probably reflects their pre-existing conceptions of what they want for treatment. There's a very big difference between the patient that walks into my office, the patient that walks into a meeting, and then the patient last week who I walked into a room that was trying to leave against medical advice with a bloodstream infection. So those are three different people. Alternatively, it could be the same person at different time points in their illness. There's availability bias. So what do people have access to? You may not have a methadone maintenance program in your community. You may not have a physician that can prescribe buprenorphine, so that really limits things. Insurance cost and distance also limit access. I've always kind of joked with a lot of my patients that if I had a board game of recovery, one of the little spots on the board would be, you just got private insurance, go back 5 steps. In Pennsylvania, we have unlimited resources with state insurance. And once someone does well enough to get a job and get private insurance, often we lose half of those resources. Telehealth is portrayed as this panacea for healthcare. It gives access to anywhere, anytime. But we know it really favors the young and technologically savvy. It may not favor our typical patient. Just a couple weeks ago at Becker's conference, which is our healthcare industry, there was actually a presentation about how innovation in telehealth might actually be widening our gaps of disparity of care for patients. And lastly, there's societal basis. So some patients feel that using medication isn't real recovery.
Okay. I think I went too far away. So we want to talk a little bit about addiction research as well, because John just went over why it can be hard to ask the question, what treatment works best for addiction? And even if you can ask the question in a neutral, unbiased way, it actually can be hard to answer. And so I'm going to talk a little bit about addiction research. I'll get a little bit technical, but you might want to know some of this information as we go through some of the data we're going to present later in the talk. So, if you want to know how to treat a disease in medicine, you do medical research, but there are some problems with addiction research that make it harder to do than some other types of areas of medicine. So the first problem, and this is fundamental, is that addiction itself as a disease is not well understood. So humans as a species, we have used mind-altering substances. It's one of the fundamental things that makes us human. We've been finding and using drugs and alcohol as long as we've existed as a species. So with that, you'd think we'd understand it better, but we do not. Even the very earliest writings about addiction in the 1600s were debating whether addiction was a disease or a sin. And I feel like we're still kind of talking about that. We still don't understand what we're dealing with. We don't understand why some people who use drugs develop addiction and some people don't. And then if we don't fully understand the problem, our research starts from flawed premises, and we might not even be asking the right questions. The second problem with addiction research is that it's often unethical to do addiction trials that are randomized and controlled. So the gold standard of medical research is something called a randomized controlled trial. You get a group of people with a disease, you want to test a treatment, you randomly divide them into two groups to make sure the two groups are the same except for the treatment you're going to try. You give half the treatment, you give the other half a placebo or something, and see which group does better. That is the gold standard on how you test a treatment. But it's very hard to do this when studying substance use disorder. So the first issue is that it's unethical to withhold treatment for a deadly disease and put people in a placebo group if a treatment exists. And for some of our more deadly addictions, we have treatments. We cannot give people a placebo for opioid use disorder if they're in a study. That would be unethical because we could treat it with, say, methadone. The second issue is that it's unethical to randomize people to receive dangerous medicines like fentanyl or methamphetamine. And actually, we do that in some trials. Like I've read randomized controlled trials of fentanyl. They're done in an ICU. The patients are literally sitting in the ICU with the ventilator right next to them. And if they stop breathing, they can immediately be resuscitated. But those are very intense. You can't do it with more than a few people. And finally, we have a lot of trouble finding good placebos. You can tell the difference between buprenorphine and a sugar pill. You just can. You can tell the difference between a stimulant and a sugar pill. Like most of the medicines we would use for addiction are potent psychotropics. So the placebos are not very placebo. They're not blinded. So if you can't do a randomized clinical trial, the next best thing is called a cohort study. So you start with a group of people with the problem, and you just let them do what they want, and you follow and see what happens. So you don't randomly assign half of them to a placebo and half to treatment. But the problem with that is that people will choose for themselves the treatment that might work for them. So it's biased by what we call self-selection. I'm going to give an example. Let's say I wanted to know whether going, and I've heard this advocated for, going to 500 AA meetings will work as a treatment for alcohol use disorder. And I want to test that. Does that really work for alcohol use disorder? So I look at people who've gone to 500 AA meetings, and I see that very few of them drink alcohol. So I might conclude that going to 500 AA meetings is a treatment for alcohol use disorder. But the problem is, of course, you only go to 500 AA meetings if it works for you. You would have to be insane to go to 500 AA meetings that don't work. And so with that, your question becomes kind of circular because the people it didn't work for dropped out of your cohort, 3 years ago. So you, instead of being able to say, going to 500 AA meetings works in general for alcohol use disorder, all I can say is going to 500 AA meetings works for people it works for. And then that is kind of circular. The next problem, so problem number 4 is most studies are short term. Like it's great if we can get someone to get off methamphetamine for 6 weeks, but what about like 6 months, 6 years, 60 years? The longest study I could find on buprenorphine was 8 years. And I've been treating opioid use disorder longer than 8 years. So where's the data to guide that kind of treatment? There are some longer-term studies of opioid use disorder, tobacco use disorder that track people over multiple decades. But they don't assess treatment. They just observe and see what happens. Short-term studies also can't measure these meaningful long-term aspects of recovery, like rebuilding family relationships or reestablishing a career. And finally, the drug supply is changing. So you might set up a study 5 years ago, but it's no longer relevant because the drugs that people are using are now different. And then number 5, every study has what we call an outcome. That's the thing that you're looking for. That's your goal. Some outcomes are simple, like death, urine drug screen results. They're pretty cut and dry. Doctors like those outcomes because they're easy for us to understand. But other aspects of recovery, which actually tend to be more important to our patients, are harder to study, like rebuilding personal integrity, being honest with yourself. How do you kind of measure that as an outcome? Medical research is mostly done by doctors, and we look for the things we care about, but we're learning more and more that this doesn't actually line up with what our patients care about in terms of a meaningful recovery. And just a final thought is that good research is expensive, and treating addiction is not a real moneymaker. There's a lot of stigma against addiction, both patients and people who work in substance use disorder, that I think keeps it from getting good funding and keeps it from getting the kind of attention that it deserves. So before we go on with that introduction, we're going to do what's called a pair and share. So rather than have everybody shout out and answer for the group, I just want everybody to be involved. Take a minute to think about your personal bias. What do you think is better? Behavioral treatment, medical treatment? Have you personally been asked to choose one over the other? Or have you been asked to choose one over the other for your patients? Do you have a personal bias? So think about that for a minute, and then turn to your neighbor and share what you thought. And if you are online on the Zoom, please put your thoughts in the chat to talk with the Zoom people. And we're going to take a minute-ish for that. All right, I'm going to bring people back. So come on back, friends. No, we can't even get people to stop talking. All right, clap your hands, be kindergarten teacher. Come on back, we're gonna keep doing this, we're gonna keep doing the lecture. All right, I hope people had, this is like an awesome sign that these questions are interesting to you. So save some thoughts as well and send them to us, we'd be very interested.
So we're going to cover here what we call the big four addictions, and we selected these based upon the fact that they have an availability of FDA-approved treatments, so we actually have medications that are studied that we can present some data on. There's also a range of behavioral health treatment options. These are substances that are problematic for patients, and we also kind of factor in the annual number of deaths attributed to each subject. So we're going to start with the first one, which is actually the most important addiction, which is nicotine. So tell me if this anyone knows anyone like this. A 46-year-old man with depression, anxiety, reactive airway disease, severe alcohol use disorder, in remission for a decade, so been going to AA, and long-term tobacco use, smoking 2 packs of cigarettes a day since 16, presents with 4 days of cough, congestion, and wheezing. He reports more frequent prolonged respiratory illnesses. This is his 4th episode this year, often requiring antibiotics, steroids, and albuterol. That's an inhaler. He has suspected COPD, but he won't go and get his testing done to confirm that diagnosis. And he now recognizes smoking's harm and wants to quit, although past cold turkey's attempts have failed. He is motivated but wary of medication due to concerns of his mood and side effects. What evidence-based options would you present to this patient? And I'm going to be transparent. I wrote this question like 1 a.m. because I was like busy seeing patients all day and then taking care of my kids and doing sports activities. And I came back to this like 2 days later, and I actually couldn't remember which patient this actually was I was referring to, because it's like a dozen of my active patients and like 12 of the CRSs I see as their primary care doctor. So a little bit of overview, like my top smoking facts. So from the CDC, there's 443,000 smoking-related deaths a year. So it's almost 500,000 Americans dying a year from tobacco use. Every year that you're alive, someone else your same age, you have almost a 300% increased chance of dying if you're a smoker. The average smoker loses 12 to 13 years of life, and that's actually a conservative figure, because if you're one of the people that actually dies from a smoking-related complication, you're going to lose 24 to 26 years of life. Everyone has heard of lung cancer, although when you actually look at the pie over here, lung cancer is a really small piece of the pie in terms of cause of death. It's only 29%. What really gets people is ischemic heart disease, stroke, COPD. Those are the big killers. One other thing I didn't add to this slide is that chronic tobacco use, it is what's called a CYP inducer. So that's an enzyme in your liver that breaks down drugs that you take in your body. And I know that you might think of illicit substance, but this could also be medication. So if you're taking blood pressure medications, cholesterol medications, anxiety, depression medications, chronically smoking will cause your body to eat up those medications quicker and could decrease their efficacy. So a couple overview of some brief skills or behavioral health interventions. So the first one is something we do in the office. It's brief advice. It's also called an SBIRT. So it's screening, brief intervention, and referral to treatment. This is something we do in the primary care office. So if a patient comes to me for another complaint, hypertension, diabetes, COPD, asthma, if smoking is part of the issue that's leading to the problem, we would briefly talk about smoking, how it's contributory. We would offer them treatments, and we would refer them to additional resources if they were agreeable. It's a quick 1-minute intervention embedded within an office visit for another issue. There's also different forms of individual and group counseling. So there's many different types. We had slides on about comparing these, although Sonia and I are kind of long-winded at baseline, so we had to cut a lot of slides. I think our original presentation was 3 times the current length, and we kept having to negotiate it down. But the most common one's cognitive behavioral therapy. There's also acceptance and commitment therapy, motivational enhancement therapy, mindfulness-based interventions. And kind of the short story about it is, while you're going to see cognitive behavioral therapy come up the most in trials, they're probably not inferior to one another for most of the data. So you could use any of these that would appeal to a patient. And last is contingency management. I'm sure many people in the room here know what contingency management is. If I talk to my physician colleagues, most have not heard about this, but this is using financial incentives to motivate cessation of a substance. In terms of medications, I'm going to use some brand names here just for ease of like almost pronunciation, because some of the words are very difficult, and people remember Chantix. But I have no financial contributions, and I drive a 12-year-old Hyundai Sonata with like a hole in the floor, so I'm not getting anything from pharmacy. The first one's varenicline. It's called Chantix. So this is a partial agonist of the alpha-4 beta-2 nicotinic acetylcholine receptor. It's basically a Suboxone for the nicotine receptor. Some noteworthy facts: it causes vivid dreams, nausea, and flatulence. Those are common side effects. You know, normally the nausea and flatulence go away, but the vivid dreams can be a barrier for some people. There's also bupropion, which is branded as Wellbutrin or Zyban. It's a norepinephrine and dopamine reuptake inhibitor, so it's an antidepressant. It also is a nicotinic receptor antagonist. Some noteworthy facts is that early studies of this drug was mostly in patients with eating disorders, and they had a high rate of seizures. So because of that, we don't give this to patients with eating disorder or seizure disorder because it's thought to lower the seizure threshold. It does have an abuse potential, so anyone that works in kind of addiction medicine, I had many patients where they'll kind of break this up, grind it up, snort it, and it produces a stimulant-like effect at high doses. Last, there's nicotine replacement therapy, and you can do a patch, gum, lozenge, or sprays. It's a nicotine receptor agonist. It causes irritation, so wherever you stick it, you'll get it. So if you put it in your mouth, it will cause irritation in the gingiva. If you spray it in your nose, it can cause nasal irritation. It can cause a rash. And actually, you can mix and match all of these to your heart's desire. So you can do 2 pills, a pill and a patch, a pill, a patch, and something short-acting. So you could really kind of go to town with this group of medications here. The first question I always get is it ever too late to quit smoking? And I would argue 100% no. There's never a time where it's too late. And I want to base that off this study. So this is from the Annals of Internal Medicine from 2021. It's one of my favorite studies. It's of 517 smokers diagnosed with lung cancer. So these are people that have smoked their whole life, and now they have an incurable lung cancer. And they followed them over time. And they looked to see for survival, but also they looked to see just how people did in general and whether they continued to smoke. And what the data showed is that actually people lived on average 2 years longer when they quit smoking, even after they have a terminal smoking-related condition. And the most important thing here is some people are like, I don't want to live with cancer and be miserable. But actually, the big boost here was actually in your progression-free survival. So like it was good years you were gaining back, not bad years. And so I always tell patients there's always an opportunity to quit smoking. I unfortunately diagnosed lung cancer more than I wish I did. And even in that scenario, if you quit smoking, you can do great. And I actually have a patient that I remember very vividly telling her that she had lung cancer when I got a call about a CT scan. I was at my friend's wedding, and I had a talk with her, and that was 8 years ago. She quit smoking. She no longer has any of her inhalers, and she has incurable cancer, but is still remission-free 8 years later. So it's amazing. It's never too late. Is it easy to quit smoking? No, it's not. No, it takes a lot of time and tries, and that's okay, and I want to normalize this, right? So this is not, if you fail, that is not a failure, a true failure. It is just one of your many quit attempts towards success. And I'm basing that off this trial. This is a really cool trial from BMJ Open in 2016, and it was about 1,300 participants that they followed. And they basically looked at recall bias. So recall bias is when we ask you to kind of write down and we study how many times you did something. We know that people's memory is not accurate. Like if I asked you like, how many times did you have chicken this past month? You might think of like a dinner you went out to that, you had a really good chicken dinner. You might think of the time that you left the grill on and burnt the chicken, but like it's not really reflective of kind of actual number of attempts. So they did statistical modeling to see how many times people actually had to try to quit smoking to successfully quit. And out of the 4 models, the lowest bias model showed it took almost 30 attempts for someone to successfully quit smoking. So that's normal. And I tell people that come into the office that say they've tried and tried and tried, just to keep trying, that they can do it, right? So next question. I'm a really busy doctor. This is for like clinicians in the room. Do I actually have enough time to cancel my patients and actually make a difference about smoking cessation? And yeah, actually, people actually value what I say about this, which is surprising because sometimes it feels like people aren't listening. And it's not only just the message, but who's the messenger. And we study this a lot for substance use disorder. And I'll tell you, for smoking, clinician message actually matters. For other substances, actually peer support actually makes a big difference compared to what I will tell them. This is a study, and it was from China, of almost 14,000 participants. So this is that randomized controlled trial that Sonia talked about. So the best trial where we take half a group into one intervention and half into another. And we looked at a 30-second smoking cessation intervention versus 30 seconds of counseling about fruits and vegetables. I'm a family doctor, so like fruits and vegetables or smoking cessation, I don't know which one I actually like to talk to people more about, but I think both are really important. And what they showed here is that after 30 days, there was a statistically significant increased risk in abstinence of smoking in the group that got that 30-second intervention. So 30 seconds of an office visit dedicated to smoking. And you may say like, oh, 6.9 versus 8%. It's about a 15% increased chance of smoking cessation. That's cumulative, right? So you can continue to do this at every visit with small interventions and increase someone's ability to quit smoking. So I've decided to take medications to help me quit smoking. Which one would be the most effective, and could it affect my mental health? So who here has heard this before, that like the medicines will kind of make them not themselves or have depression or anxiety? Yeah, this is a lot of this comes up. So varenicline, which is Chantix, is considered the most effective medication on smoking cessation, and the research would show that it's actually very unlikely to affect your mental health. And I'm basing that off of this trial called the EAGLES trial. And this is probably the most important smoking cessation trial, I think, to date in like the history of smoking cessation. It's from 2016, and actually it looked at 8,000 participants with smoking, and actually it grabbed people with and without psychiatric disorders, which I think is really important because a lot of times these trials will cherry pick easier patients to prove a point, but they did not here. They actually took all comers, and they randomized them to treatment with varenicline, which is Chantix, bupropion, which is Wellbutrin, a nicotine patch, or placebo. And actually, the primary outcome wasn't abstinence, although it was one of their primary outcomes. The number one thing they were looking at is what's called neuropsychiatric side effects. Did this affect someone's mental health or mood? And what it showed that throughout the trial for the 12 weeks, which normally these medications are relatively short-term for smoking cessation, that actually there was no difference whether we gave you a sugar pill or we actually gave you varenicline for a neuropsychiatric side effect. So it was effective. Not only that, varenicline was the most effective by far, a 21.8% abstinence rate. It outperformed the other interventions, which were 16.2% for the bupropion, and then 15% for the nicotine patch. And interestingly, placebo had 9.4%. So even just telling someone that I'm giving them something to quit smoking, it works 9% of the time at least. All right, one more parent share we have here. Should people in recovery be advised to quit smoking? Should smoking be allowed at addiction treatment facilities? Have you ever been pressured to quit smoking? Was it annoying? Well, why don't you take a minute here?
everybody back. Come on back to us. Excellent. I'm glad people have a lot of thoughts about this. This has been a very controversial topic in recovery. Okay. So I want to talk about our next big addiction, which is opioid use disorder. So this is the one that gets all the press, even though it's not the one that kills the most people. I'm going to start with a case. This is a patient in our practice, and the recovery support specialists who work with me will recognize this patient, but hopefully nobody else will. And this case highlights not only a patient's standard journey through opioid use disorder, but also my personal journey as a doctor, as I've worked with this patient over many years. So this is a lovely person. She had a surgery at age 16 to remove an ovary, and ever since that surgery had chronic pain and received chronic opioid prescriptions on and off. Between 2010 and 2017, this lovely person had a daughter, started using IV heroin, multiple stays in inpatient rehab, multiple prescriptions for controlled substances from her various doctors for chronic pain, contracted hepatitis C, many passes through treatment, had another pregnancy, and with that second pregnancy, decided to seek out a sustainable treatment for her opioid use disorder. So then she walked into our office pregnant, and was started on buprenorphine or Subutex, 8 milligrams twice a day. Her pregnancy was uncomplicated. She remained abstinent from all drugs. She had a beautiful child. And at that time, we required all of our participants to participate in recovery support managed by a local recovery program. We require group attendance, weekly visits with a peer support specialist. We require abstinence from all illegal drugs to continue to participate in our program and receive buprenorphine. So that was the context that she came to us in. Over the next 2 or 3 years, she got a little sick of me, a little sick of our program, and tried twice to taper off her buprenorphine. Both times she relapsed. Once she got down to a low dose or stopped it. Both relapses were very traumatic. And in the end of 2019, she decided to return to buprenorphine for good. By 2019, I was no longer working with that community recovery program, and we did allow patients to get their medication without compelling them to do any other kind of treatment. We offered it, but we did not require it. So she's been stable and drug-free on 16 milligrams daily of buprenorphine. She has no desire for additional behavioral treatment. She also uses medical marijuana, which would not have been allowed in our previous program. She works to support her daughter. She has a stable partner. She plans to stay on buprenorphine lifelong. And reflecting on this case, I just think of the differences in my own treatment from 2017 to now. So again, I no longer require patients to participate in behavioral health treatment like groups or individual therapy. I treat hepatitis C now. I did not before. I also see how her doctors were very free prescribing opioids to her, even though she had obvious and diagnosed opioid use disorder. And no one addressed this chronic pain that she had since she was age 16. They just gave her opioids for it. We also don't require abstinence from other drugs anymore. If you use other drugs, our goal is to help you get off those drugs, if that's your goal. We do not kick you out of treatment because of it. And also now medical marijuana is legal in Pennsylvania, which was not true before. So this patient and I have been on a real journey together. So the main reason to treat opioid use disorder is that we are in the middle of an opioid overdose crisis in the US. So 80 to 100,000 people die every year from drug overdose. For the last 5 years, most of them from opioids, some from other drugs, but most are opioids. Thank the Lord that the trend is reversing over the last 2 years. You can see that curve is bending down, and I hope it will continue to go down. In just a moment to thank everybody in the audience for the work you do. We have saved at least 20,000 people a year over the last 2 years with all the work that the recovery community does. So here's a list of some, but not all, of the treatments for opioid use disorder, the behavioral treatments, the skills. As you can see, there's quite a few behavioral treatments that are available that people use, as there should be. Some are the same as the ones John talked about for smoking cessation. The two that are most effective that you should remember are contingency management and cognitive behavioral therapy. Those have the best data. And if you remember, contingency management encourages positive behavior by providing rewards, usually monetary, sometimes more like food or items. And cognitive behavioral therapy is a therapeutic technique where you work to change your own negative thoughts and behaviors. So, but different from smoking cessation, many of the behavioral therapies for opioid use disorder are aimed more at getting your life back after the chaos that's caused by opioid use. So people often need help with housing, with employment, legal issues, family relationships. They may need inpatient treatment because they're unable to manage withdrawal. Their life may be at risk in the short term from extreme drug use. So some of these therapies are a little different than the smoking cessation therapies. There's also medications for opioid use disorder, very effective. So there's 3 main meds that work for opioid use disorder. The first is methadone, and I think of methadone, if you think of the opioid receptor is like a door to your pleasure reward centers. This is metaphorical, okay? It's a door. Methadone walks right through that door and activates those receptors, just like fentanyl. It's very effective. It prevents withdrawal. It gives you the same boost that other opioids would give you. It's a complete replacement for fentanyl or other illicit opioids. The next one is buprenorphine, which is known as Suboxone or Subutex. So buprenorphine kind of goes halfway through that door. It blocks it, so other things can't come in. It blocks all the illegal drugs, but it also is partly in the room. It's doing some of what the other opioids would do. It's about 40% of what your fentanyl might do. So it gives you some of that boost, but not quite as much as something like methadone might, but it blocks the other drugs. Finally, you get Vivitrol, which is, again, the brand name. It's a little more recognizable than its generic name, which is naltrexone. Naltrexone just blocks the door. It does not go through. It gives you no pleasure boost. It just stops everything else from coming in. It can reduce cravings. It can protect you from all these other drugs, but it doesn't give you any of that kind of boost that the opioid agonists will. And I also put 2 other categories of medications on this slide. Naloxone, which is Narcan, and then a bunch of meds for withdrawal management, because they don't specifically treat the opioid use disorder, but they are key parts of medical treatment for opioid use disorder, preventing overdose deaths and then managing withdrawal, because withdrawal is one of the main drivers in relapse. So first question my patients ask me, what if I don't want to go on medicine? I don't want to be addicted to another drug. That's a very real concern for people. So data has shown that medication, specifically buprenorphine and methadone, will reduce death by 50 to 70% in patients with opioid use disorder. Medication works quickly, within hours. It restores balance to those pleasure-reward circuits that have been dysregulated by opioid use disorder. And given the potential for death, medication must be offered to everyone seeking treatment. They don't have to take it, but it has to be offered. With a disease that could kill you, you cannot not offer a medication that will reduce that chance of death. It won't solve all your problems, I will admit that, but it will create mental stability so that a patient can actually address those mental, spiritual, and psychosocial aspects of opioid use disorder. So I think this is the study that Tom was alluding to that got us invited to this conference, and we basically trolled the entire addiction recovery community by talking about this article. It was pretty controversial, and it's not that the data was wrong, but the conclusions really ruffled a lot of feathers. So it was comparing rates of death, people who died in the state of Connecticut, after receiving different treatments for opioid use disorder. And so the treatments they were able to look at were methadone, buprenorphine, inpatient treatment of any duration. They had it broken down into short and long-term, like detox versus rehab, but I kind of bunched it all together. And then people who got no treatment at all. And so there's a ton of caveats, most notably that this study did not include outpatient behavioral treatment, and it also didn't really look at inpatient plus medication. If you went to inpatient and then got started on meds, and then you were considered medication, not inpatient, even though inpatient was what got you on the medication in the first place. So a lot of caveats, but bottom line, you can see that in people who got methadone, there were 6 deaths per 1,000 patients per year. In people who got buprenorphine, 6.5 deaths per 1,000 patients. People who got nothing, 10 deaths, more or less, per 1,000 patients. And people who went to inpatient, there were 17.4 deaths per 1,000 treatments. So basically, it showed that going to inpatient treatment was worse than getting no treatment at all. It was very sad. Methadone and buprenorphine were associated with a reduced risk of death, but again, exposure to this short and long-term treatment provided no protection against fatal opioid poisoning. So it gives you something to think about, right? And what this study did for me is that I'm not against inpatient treatment. We facilitate people going to inpatient treatment all the time if they want it. But I used to assume that inpatient treatment would be the best. Sickest patient, highest level of care, inpatient. And I just don't think I believe that. I don't think the data backs that up, that the sickest patients get the best care in inpatient treatment. So if someone asks me if they have no idea what they want, I would say intensive outpatient with medication would be the most effective. Because it really helps you, it stabilizes you, but also gives you skills that you need to cope with opioid use disorder in your home setting, rather than at a sort of closed inpatient treatment center. And since this is a talk about comparing buprenorphine to other treatments for addiction, or comparing treatments to addiction, I want to just stop and take a minute to compare buprenorphine to other primary care things we do. So in medicine, we use a statistic we call the number needed to treat, which is how many patients do you need to treat to prevent one death or one negative outcome. So you can see here that statins like Lipitor and Crestor, we need to give statins to 83 people with heart disease for 5 years to prevent one death. For mammograms, I know all you ladies hear me, all like the breast squishing mammograms, we need to give 1,000 women mammograms for 10 years. That's 10,000 mammograms to prevent one death from breast cancer. Blood pressure medicines, we have to give 125 people blood pressure medicines for 5 years to prevent one death. Buprenorphine, 53 people for 1 year to prevent one death. And to cure opioid use disorder, basically, to eliminate opioid use disorder, we need to give buprenorphine to 2 people. So buprenorphine is more effective than almost anything else we do in primary care in terms of preventing death. One of the most effective interventions we have in our medical toolbox. Okay, fine, I listened, I'll take medication. But which one? Which medicine to take? So comparative effectiveness research between methadone, buprenorphine, and naltrexone, which is Vivitrol, it's not great. All 3 treatment experiences are so different, it's really hard to say which one is best. But in general, methadone seems to prevent the most deaths and keeps people in treatment the longest. So this is a modern study. A lot of our methadone data is old, and the drug supply has changed, and buprenorphine is now available, which wasn't before. But this is a brand new study from JAMA, Journal of American Medical Association, last year. So importantly, I have to say, it was done in Canada, where there are fewer regulations on methadone and more regulations on buprenorphine. So basically in Canada, methadone and buprenorphine are treated the same. It's the same treatment experience to get both in terms of take-homes and other requirements. So you can do a good head-to-head comparison. And you can see here that for people who are trying medicine for the first time, methadone kept people in treatment longer, although at 24 months, which is 2 years, most people had dropped out of treatment because most people take multiple passes through treatment. But 81% of the methadone people had dropped out, and 88% of the buprenorphine people had dropped out. So the methadone kept people in treatment longer. In terms of death, there was a slightly higher death rate in the methadone group, but those 2 were considered statistically the same, and there was very low rates of death overall. So what this says to me is that as soon as methadone is liberated and deregulated, which I think it will be relatively soon, I will be adding it to my personal arsenal. I will be prescribing it in primary care as soon as I'm allowed to for patients who want that. And I think it will be effective, and in many cases more effective than buprenorphine. So next study is about naltrexone, which is Vivitrol, is the brand name. So that's an extended release, once a month injection. Also comes as a pill, but this study was about the injection, comparing it to buprenorphine. The biggest problem with naltrexone is that it's a full opioid blocker. And for anyone who's ever taken it or worked with patients on it, you'll know you have to be completely opioid free to get your first shot, or you'll go through precipitated withdrawal. That means 7 to 14 days, especially with fentanyl. It can be up to 14 days to clear it all out of your system. And patients say, if I could go 7 to 14 days without drugs, I would not be here. I wouldn't need treatment. I can't go 7 to 14 hours without drugs. And so it's really hard to get them onto this Vivitrol, onto the naltrexone. But it's very useful for people who've already gone through that detox and are opioid-free. And it really shines in the setting of relapse prevention. So in this study, you can see here, this was kind of amazing data, that the risk to first relapse was reduced by 65% with naltrexone compared to buprenorphine. And the risk of any relapse over the study time period was reduced by 92% naltrexone compared to buprenorphine. It worked almost twice as well as buprenorphine for that outcome. And then when they continued the study for 9 more months, people could continue their naltrexone or stop it. The people who continued had a 55% reduction in relapse. So I was really surprised by this, and I always pay careful attention to research that challenges my preconceived notions or challenges what I thought I knew. Most of my patients are not looking for Vivitrol, they're looking for buprenorphine, and that's fine. We're happy to have people try whatever treatment they would like. But it really showed that for relapse prevention, it worked well. And it's made me very comfortable offering this medication for patients, especially if they don't want to be addicted, they don't want an opioid that they'll have to suffer withdrawal from if they stop it. Another question patient might ask, should I also go to therapy? How effective is mental health treatment if you add it to medication? So this is a really hard research question to answer. There's no single study, given all the different kinds of psychosocial treatments, all the different medications, all the different treatment settings, different outcomes, but a meta-analysis, which is a study that pulls together lots of studies into one, concluded that psychosocial therapy will somewhat improve outcomes added onto medication. And the 2 techniques that have the best data are contingency management and cognitive behavioral therapy. But I just want to point out, it does help, but behavioral intervention should not be mandatory. It should not be compulsory. We should not kick people off medication if they do not want to participate in behavioral health treatments. So, okay, fine, maybe I'll add behavioral health, but I can't find a contingency management program because there's no funding, my insurance won't cover therapy. Is there something I can do on my own that would help me? And yes, there are many things patients can do on their own. So this was a study published in JAMA Psych last year about an intervention called the Mindfulness-Oriented Recovery Enhancement. So this was people on methadone. They went through an 8-week online program focusing on 3 different cognitive behavioral techniques. They're called mindfulness, savoring, and something called reappraisal. And the goal of this study was to improve the dysregulation in this pleasure-reward system that kind of underlies some of the problems with opioid use disorder. And it was pretty effective. So you can see that people who got the mindfulness, I put mindfulness like as a pill, they got mindfulness, 50% returned to drug use compared to 57% who didn't get mindfulness. And they were less likely to drop out of their methadone treatment, and they used less drugs, less days of drug use overall. So, how would I use this personally? I mean, I can't run this MORE program, the Mindfulness-Oriented Recovery Enhancement. I'm not a therapist. I don't have the training to run a program like this. But the techniques used in this study are very common. They weren't weird. They're well-known cognitive behavioral therapy techniques. Information about them is widely available. Actually, Psychology Today, which is a resource I use a lot, they have 3 beginner articles, 1 on each of these techniques, and I can refer people to those articles plus a free app if they want to do more structured work on their own. And so a lot of information. We're going to take another quick break. We're going to do one of these mindfulness exercises as a pair and share. So this is one of the exercises in that intervention called savoring. And anyone who went to the talk just before us on prolonged acute withdrawal syndrome on pause, we talked a little bit about this as well. So it's the mindful appreciation of a positive experience with the goal of increasing your positive emotions and augmenting your natural reward processing. So everyone is going to silently think, or you can talk, but think of 3 things that give you pleasure. Don't think too hard, just 3 nice things. First sip of coffee in the morning, your child's smile, the beautiful weather outside, and then choose one thing from your list. Think about how you'll feel when you next get to experience it. Really put some detail into that mental snapshot. And then turn to your neighbor, so give a moment to think, and then turn to your neighbor and describe that mental snapshot. I'm going to bring people back. All right, come on back. I hope everyone is feeling a surge of positive emotions, thinking about their nice thing and savoring it.
All right, coming back. All right, so our next case, kind of moving forward, so this is for alcohol. It's a 45-year-old man with a past medical history of high cholesterol, type 2 diabetes, depression, and severe alcohol use disorder. They present for routine follow-up. His labs show elevated liver enzymes, so he has liver damage going on, hyponatremia, which is a complication of chronic alcohol use, and his diabetes is poorly controlled. He reports drinking 16 to 20 beers daily, although his wife in the corner of the room reminds you it's actually a 30-pack. And by 10:15 a.m., he has already had 6 beers prior to the office visit. He describes ongoing depression, lack of interest in activities, and dependence on alcohol to start his day. He has never tried medications or formal treatment, but briefly attended an AA meeting and said it wasn't beneficial to him. When asked about his goals in treatment, he says, "I don't know, but something has to change." What evidence-based options would you recommend for this patient? And this is a real patient, and for 2 years, this gentleman came in to see me every 8 weeks, and we'd have a meeting, and literally it was the exact same visit every other month for 2 years. And I was racking my brain up, like, what do I do differently? I would try like motivational interviewing. I would try to offer treatment. I'd have my CRS reach out to him. I'm like, oh, I got a Vivitrol sample. Would you like to try that today? And literally, he never bought, but he did come back every 8 weeks for that visit. So a little bit about alcohol. So, here's my top alcohol facts. We are in a very alcohol-centric society here in the United States. Certainly, there is a lot of difference based upon generation, but I think this is a staggering statistic. Approximately 29% of U.S. adults will meet criteria for alcohol use disorder at some point in their lives. That's a third of U.S. citizens will meet criteria for this disease. That's incredibly high, and that was from the NESARC trial. When you look at deaths per year, there's 178,000 deaths attributed to alcohol per year. And it was up from 2016 to 2017, although, like I said, we do see generational changes in alcohol use disorder. And a third of those deaths, 61,000, come from the kind of the players you would think of for alcohol use, alcohol-related accidents, overdose, suicide. But 2/3 of them, 117,000, come from chronic conditions. So that's things like hypertension, heart disease, stroke, liver disease, cancer. Alcohol is a major carcinogen. We're linking it to more and more cancers. It's been heavily linked to breast cancer, and we just didn't know that beforehand. We thought liver disease. There's 4 million years of life lost through this disease, and if you die from one of these alcohol-related complications, you're averaging 24 years of your life that you're giving up for this. 2 other little interesting facts. We love studies that tell us stuff that we want to hear. Like, how many studies have you seen that, like, eat chocolate, you'll live longer, and drink coffee, it's good for you, which it probably is. But for a while, there was all that stuff about, like, drink your 2 glasses of wine every night and you'll have better heart health. And, I tell people that's actually been, like, totally debunked. So there is no safe amount of alcohol consumption. I'm not saying you should never drink if you can drink in moderation, but every ounce of alcohol you put in your body does have adverse effects. There's even a study showing, based upon modeling, at what age can you drink freely without it impacting your health, and the age was like 78 or 80. It was like well into your retirement years. So grandmom at like the happy hour at the retirement community, I guess she can go for it, but the rest of us should probably go with moderation. So a couple things about skills here, behavioral health interventions. Many of our kind of repeat players here. The 2 that I wanted to bring to everyone's attention that kind of come up quite a bit is one is 12-step facilitation. The most common form of that, as everyone knows about, is Alcoholics Anonymous. It's a peer-based abstinence program. The other one that increasingly you'll hear a lot about is this moderation management program. It's similar in terms of its structure for a peer-based program. It's for non-abstinence seeking individuals. And a lot of the format for this is either self-guided or online. There's not quite as much of a live following for this, but it's something that comes up quite frequently, at least in the office with me. In terms of medications, we have a little bit more in terms of options here. So naltrexone comes in 2 forms, Revia or Vivitrol. One's an oral pill, one's a shot that you take once per month. You can't give this to someone with liver dysfunction. Interestingly, you can start this medication for alcohol at any time point. So actually at our hospital, we recently started a program where we offer this to patients in acute alcohol withdrawal if they would like to get it at that point in time. You can also use this as needed. This is kind of gaining popularity even on social media, the Sinclair method, where someone takes naltrexone on just instances where they're at risk for drinking. So like on Friday, Saturday night when they go out. There's acamprosate, Campril. This modulates the glutamate receptor, which is our excitatory neurotransmitter. It kind of helps with anxiolysis in between drinking. You can't give it in renal dysfunction. It's got a very weird dosing schedule. So it's 666 milligrams, like the number of the beast, 3 times per day. And so like, it's very difficult for patients to take 6 pills a day at 3 different time points. It's really tough from a compliance standpoint. And then there's disulfiram, which is antabuse, and this is the medication everyone thinks about when we talk about alcohol use disorder. It inhibits aldehyde dehydrogenase. That's an enzyme that breaks down alcohol. So as you drink alcohol, you build up these toxic metabolites and you feel sick. It can cause nausea and vomiting with alcohol. Patients have told me they've had things like salad dressing with trace amount of alcohol and gotten sick. I'm not sure if that's 100% accurate, but I'm told this quite often. And it may produce like a garlic-like body odor. It's very interesting. This medicine, it simulates in life what happens with a lot of Eastern Asian patients that have an inhibition of this enzyme naturally. So that's why that population tends to drink less alcohol, because they can't tolerate it as well. They don't feel well when they drink. Those are the only 3 on-label medications. So those are the only 3 FDA-approved options you have. And to let you know, so the first one was approved in 1951 or 2. That was antabuse. And so in 75 years, we only have 3 drugs in this domain, despite this such a common problem. Off-label, we use gabapentin or Neurontin that modulates GABA, which is an inhibitory neurotransmitter. It can cause respiratory depression. People forget that when you add this with respiratory depressing medicines like benzos, opioids, Suboxone, or methadone, it can cause overdose. And it has a high abuse potential. We're seeing more and more of this. It has a benzo-like effect at higher doses. There's topiramate, Topamax. This is an anti-seizure medication. It enhances GABA activity and modulates that glutamate receptor. It's off-label, so you can't prescribe this as part of an FDA-approved treatment process. At higher doses, it definitely causes cognitive slowing. The neurologists nickname it Dopamax because when you take it at higher doses, people feel kind of not quite themselves in terms of their thinking. And it can cause like paresthesia or like a tingling sensation in some patients. Certainly failure is the greatest teacher of all. And like early in my career, I started a patient on this and they developed like tingling in their face and they went to the ER for a stroke alert and I felt really bad about it. So I tell people about this quite a bit now ahead of time. So I've been struggling with alcohol and my doctor previously suggested I try Alcoholics Anonymous. Does it actually help? And the answer is yes. For individuals who are committed to participating in this program, definitely can be very helpful, or 12-step facilitation as a whole can be highly effective. This is a randomized controlled trial from Journal of Substance Abuse looking at 121 patients with mental health illness randomized to 12-step facilitation or treatment as usual. Now, this group was randomized, so they were kind of told to go to 12 steps. So this isn't the group that's kind of self-selecting. And it was a 12-week trial with 36 weeks of follow-up. And when you look at it as a whole, if I just took half the room and made you go to 12 steps and half the room that I made you not go to 12 steps, actually both groups are going to be about the same. But for the patients that actually continued treatment with 12 steps, so the group that kept coming back, it was incredibly effective. It decreased your drinks per drinking day, increase your time of abstinence. So for the group it works for and then actually keep coming back, it works very well. So like 50% of the time, it works all the time. I'm not interested in taking medications or committing to an abstinence-only program like 12 steps. Are there any approaches that can help me reduce my drinking without requiring me to quit entirely? And I think that like this is probably the first question I get from every patient that comes to my office. And I would say that I'm probably preaching the choir here. This is really, really debatable topic, right? There is some very, very limited evidence that a moderation management approach may help. And I'm going to kind of show you the limited data we have about that. And so this was like the only thing I could find about this program from an actual clinical journal was from 2009. And it was a randomized controlled trial of kind of a low size, only 84 drinkers. And it basically randomized them either to they got literature to read about moderation management, or they got the literature, plus they would attend these group-based moderate drinking programs scenarios. And what it showed that over 3 months, the group that did the moderate drinking program actually did better. But when you kind of dig into the details here a little bit, while they had better outcomes, absence was only occurring in 27%, which was better than the treatment as usual, which is 14.5%. But your average drinks per day, which while better from 5.7, we're still averaging 3.7. So like it decreased their drinking, but these patients were still drinking. So the question kind of back to the patient would be, would that get you to the outcome that you're desiring? Is decreasing to that degree going to make your life a better situation or not? So there is evidence it can be helpful, but it's a reduction, not kind of an elimination. I'm open to taking medications to help with alcohol use. Which one would be best for me? And so like there's definitely not a one-size-fits-all approach here, but I would say that naltrexone, acamprosate, or a combination of the two are the most effective. Certainly, disulfiram we'll talk about in a little bit. It can be effective, but just for a patient-centric approach, the data points the most towards these other medications. This is another double-blind, randomized, placebo-controlled trial from JAMA in psychiatry in 2003, and it compared patients that received a placebo, naltrexone, acamprosate, or naltrexone and acamprosate. And in terms of drinking outcomes, so time to first drink, volume of drinking, and patients did well in the following order. The best was a combination, so the naltrexone and acamprosate, although that had the highest rate of poor tolerability. So, 2 medications, that would be 7 pills per day, clearly not probably ideal for some people, but that had the best drinking-related outcome, followed by naltrexone, followed by acamprosate. So that was kind of the 3 drugs in order. What about the medication that makes you feel sick? Could that work for me? So disulfiram isn't our first choice due to patient concerns. I gotta say, most patients are aversive to the idea of a medication for alcohol use because they've heard of this drug. Many people have. If I take this, I'm gonna get sick and throw up. And I feel kind of bad offering it as a first agent for patients just because it doesn't sound like a very patient-centric outcome or people aren't going to feel great about it. But actually for the right patient, it's probably our most effective treatment. And this is based on a study from Alcohol and Alcoholism from 2008. And it was another randomized open-label study. And it actually put the 3 drugs head-to-head. So the same drugs last time with counseling. So everyone in this trial got cognitive behavioral therapy counseling. And you got either disulfiram, naltrexone, acamprosate with your therapy and counseling. And it was 12 weeks of supervised medication, so we knew the patients were actually taking these medications with up to 52 weeks of targeted use for those patients. And what they showed the first 12 weeks is that clearly the disulfiram group outperformed the other 2 groups. So it was 32 days to first drink, compared to 21 days and 19 days for the other 2 treatments. Naltrexone was second and acamprosate was third. I think it's really important, though, to note here that that was our most effective drinking-related medication. But if you look at those outcomes, so you still have 3 heavy drinking days per month, and you're still drinking more than half the week. So, or about half the week. So, the question becomes, is that the outcome you're looking for? It is effective compared to placebo, but people are still drinking at probably will be considered an unhealthy rate. When you look at longer on as the trial progressed, the disulfiram group definitely kind of outperformed the other ones, which continued. So I think for the right patient, I do have some patients that have tried the other medications and they feel that this medication is the best for them and they actually advocate for them. They feel like it has some degree of accountability. I'll prescribe it in that situation, especially if they've tried the other options first.
All right, so everyone has stuck with us this far. So this is our final drug we're going to talk about. And everyone here has amazing endurance because I know this talk is a lot. So this is a patient that, again, the CRSs that we work with know well, 34-year-old woman, terrible history, long history of childhood trauma, physical abuse, sexual abuse, including being thrown out of a high window as a child, suffering traumatic brain injury, and pretty much all the mental health diagnoses. I don't know which of them are true, but she's got them all. She seeks care with me for opioid use disorder with buprenorphine. She's been stable for quite a while, even before she came to us. After seeing us, she was stable for about a year on buprenorphine, and then she got involved in methamphetamine. And with the methamphetamine, she loses her home, her relationship with her husband, custody of her children, her job, her psychiatrist. She loses all her medicine several times. She ends up living in an encampment in a local city park. She continues to use methamphetamine and probably fentanyl. She is unable to accept help despite our fearless outreach workers going to her, finding her on the streets, meeting with her multiple times to try to get her help and resources. And we have not heard from her in about 8 months. We have not been able to contact her. And this case study is typical of what methamphetamine can do to you. While methamphetamine and stimulants in general, like cocaine, don't cause quite as many deaths as opioids, they just bring a level of chaos to your life that makes it very hard to manage and will bring you down in a different way. So, we are in an overdose crisis. This is another graph from the CDC showing deaths broken down by type of drug. So the very top are opioids, of course. The black line is all opioids. The brown is fentanyl. So you can see fentanyl is most of the opioid deaths. And then keep going down. The next two are stimulants. So gray is methamphetamine. Purple is cocaine. So they're not as bad as opioids, but they do cause a pretty significant number of deaths, and they bring chaos to your life, as I discussed in my case study. And I put this in here. I'm sorry this isn't updated. The CDC hasn't produced a new version of this graph for 2025. So this is 2022 before the deaths started going down again. But the point is the same, is that most people who die from stimulant overdose die from stimulants die from opioid overdose. Most methamphetamine deaths are from opioids. 2/3 of the people who die with stimulants in their system died from opioid overdose. It may be known, they know they're using both drugs, or it may be unintentional that the methamphetamine might be contaminated. So we estimate that about 12 to 15% of the powder stimulants, powder cocaine, powder methamphetamine, has fentanyl in it. And this is the setting where fentanyl test strips are most effective for patients. Not so much for opioid users. All the opioid is fentanyl. It's like there's no point in testing it for fentanyl. It is fentanyl. But the methamphetamine needs to be tested for fentanyl. So behavioral treatments are the first line for stimulant use disorders. We do not have effective medication. Contingency management is most effective, but there are several other approaches recommended by the American Society of Addiction Medicine and the American Academy of Addiction Psychiatry. And then there are medications, as I said, none are FDA approved. The two most common are topiramate and bupropion plus naltrexone. You might recognize these drugs from the other slides. We kind of repurposed other medicines to see if they would help with stimulant use disorder. Topiramate is the first choice for cocaine use, and a combination of bupropion plus naltrexone, so Wellbutrin plus Vivitrol, is the treatment of choice for methamphetamine. The big caveat for that is you can't go on naltrexone if you're on opioids. So our patients who are on buprenorphine but struggling with methamphetamine use can't take this combination because of the naltrexone. We also use mirtazapine. We try to use long-acting amphetamines, like Adderall, Vyvanse, Concerta. Helps somewhat with cocaine use disorder, but not with methamphetamine. And we try to use bupropion alone. Doesn't help that great. So first question, you'll pay me to stay off meth? Ooh, how much? $1 a day. We'll pay you $1 a day to stay off meth. And that's all it takes. So contingency management, paying people to stay off drugs. These monetary rewards give you that dopamine boost that replaces the methamphetamine. You get a reward for providing drug-negative urines, going to treatment, doing health-promoting behaviors. So this study, which is one of the most robust for contingency management, you got $365 over the course of a year if you did all the things you were supposed to do. And you can see that the contingency management group, they had many more health-promoting behaviors, like going to the doctor. So almost 16 in the year compared to 1.6 for the non-contingency management group. They had more methamphetamine abstinence, 69% versus 48%. So that's about a 20%, 23% increase. And any drug abstinence, 61 versus 36%. And this was not expensive, $365. Like, think how much it costs to go to the ER with methamphetamine-induced chest pain. Very cost-effective intervention. Sorry. So next question you might ask is, what about like the Suboxone of meth use? Can't I take Adderall instead of using meth? Wouldn't that be healthier for me? Sadly, no. Prescription stimulants do not work for methamphetamine use disorder. And just to show this trial really quickly, it's a negative trial testing lisdexamfetamine, which is Vyvanse brand name, for the treatment of methamphetamine use disorder. Brand new study came out in the journal Addiction. There was no difference in the daily probability of methamphetamine use in people who got the Vyvanse versus people who got placebo, unfortunately. is there any med that will help me stop using meth? Maybe just a little. So some meds help a little bit. Like I said, this naltrexone plus bupropion, which is Vivitrol plus Wellbutrin. Patients who got that combo in this trial, the ADAPT-2 trial, had about a 27% reduction in use in methamphetamine positive urine drug screens compared to placebo. Again, we gave people sugar pills and they had 11% reduction in meth use, so that's good too. So it didn't work great, but it was very safe, no adverse outcomes, and certainly better than doing nothing. So this is our final pair and share, and because we're running a little bit out of time, we're not going to have people talk because you guys love to talk, apparently. But think about it. Did you learn something new? Has it changed your thinking about medical and behavioral treatments? Did we get anything right? Did we get anything wrong? Especially if we got stuff wrong, we want to hear it. So we're going to do a Q&A. We want to hear your thoughts. You can put thoughts in the chat. You can come talk to us later. We'll be around at the conference. Or you can email us, addictionmedicinejournalclub@gmail.com.
All right, hold on. We got 3 slides. Sonia took my thunder here.
Sorry.
All right, quickly here. So kind of key takeaways here. One is I want people not to think of addiction medicine as one size fit all. Certainly behavioral and medical treatments both have value, and probably the best treatment approach involves a combination of the two. We talked a lot about research here, and I think that we do need to acknowledge the fact that research in this domain of addiction medicine, it's not what we get for other forms of medical literature. It's poorly funded, design is often different, they're short-term, outcomes are typically not patient-centric outcomes. I would argue, do we even really have a great understanding yet of what patient-centered outcomes look like for this population as the medical community? That's kind of a lame answer, so I guess here's my final answer about this. If someone asks what's better, medication or behavioral health, I'd probably start with a question back to them, what do you want? Do you want negative urine drug screens? Do you want to decrease your rate of HIV or hepatitis C? Do you just want to stay in treatment? Do you want to take a harm reduction approach while still using illicit substance? If that's what you want, I probably got a pill for that. I could help you out. If you want abstinence, employment, improved relationships, this kind of global well-being, which we're increasingly recognizing as kind of the gold standard outcome, you probably want to approach a behavioral health intervention. Medication-centric approaches are incredibly effective for, I say, first, opioid use disorder, number 1. These medications save lives, they prevent overdose. Tobacco use disorder, they can be very helpful, mostly because that's a very difficult substance to quit, and we do have a fair amount of data on our currently existing options. I put alcohol use disorder with a question mark. Like we talked about from these trials, the medications will decrease volume of drinking, but patients will more than likely still drink, and they more than likely will still drink at an unhealthy level. So it may be a harm reduction approach. It may not get you that global well-being outcome that many people are looking for. Behavioral-centric approaches are helpful for stimulant use disorder. You know, for something so common, we don't have anything yet, to be quite honest. I mean, we have a limited data about the naltrexone Wellbutrin combination, but besides that, we don't have much data. Patients that prefer non-medical approaches and have strong support networks, well, I'll always work with you. That's great if you want to pursue a non-medical option. And then I do have patients that, you know, they've tried medications, they just can't tolerate them. That's another great group to look into behavioral health resources. Final thoughts for anyone in the room that's a provider or a prescriber, I would say, like, keep learning, stay humble. I think as a medical community, we really struggle at times with substance use disorder, mostly because to get into medical school, you're kind of type A, you're rigid, and you really need to be flexible and work with people at different stages. So it's kind of it's a very humbling experience. And I've actually become a better doctor with my other patients working with this population. You need to listen to what your patients need and offer treatment even if it's imperfect. So especially like the methamphetamine use disorder, we don't have a great answer there, but there's things we can try if you're really struggling. And then lastly, I think this is a really rewarding part of medicine. I'm a primary care doctor. This does not belong to psychiatry. This is a primary care problem. Anyone that can prescribe can do this in your office and save lives. The more barriers that we put in to limit someone's access to these life-saving medications, the more likely you're going to have a patient overdose and die. For my non-physician colleagues in the room, please support everyone without judgment. It's really leveling for a patient that's using medication as part of their recovery. when they kind of mitigate their legal problems, they get control of their child, they get custody back, they're back in school or they're working, and then someone at a meeting tells them that they're not in real recovery. It can level them and really set them back. If you're struggling with someone that you know that has a substance use problem, don't assume that your doctor can't help you. Come to us. And if your doctor can't help you, they can refer you to someone else. And if they really can't help you, then get a new doctor. And lastly, kind of in today's climate, you need to advocate for access, equity, and long-term engagement. We need funding to kind of develop drugs, study these things, and I wish that we had the funding for this domain that we had for other conditions. All right, thanks, guys.
Okay, so we've got time for maybe 2 questions. So who's got it? All right, one in the back.
Hi, how are you guys doing? Can you hear me all right? Yeah. What's your opinion on accelerated detox, the procedure where people go through detox really quickly with now, I think like naltrexone, often Lyrica. I'm not a physician, so I don't know, but yeah, that's my question because I didn't see it in your presentation, and I was just wondering what your opinion on its role is.
I got thoughts on that. I'm sure you do too. I mean, basically, detox alone is not effective. So going through detox and withdrawal and then coming out to nothing is not effective. Just managing the withdrawal is not what most people need. So if you use it as a bridge to long-term outpatient treatment, sure, more power to you. But as a single thing, I would not recommend it. Not that it wouldn't get you through detox, but it just doesn't solve your problem long-term.
Yeah, I agree. I think we've kind of established that detox is a start of a treatment plan, right? A bridge into something else. There's a lot of data on detox no matter how you do it. If that's your only treatment plan, relapse is very high. I think it's like 50% the first day of discharge. So it needs to be part of something else. And in terms of how quickly you do it, I know that people are doing it different ways. I've even seen a study about someone that puts someone under general anesthesia and rapidly detoxes them. And I've not seen any evidence that that improves long-term outcomes to any degree. But we've tried it.
One here. That was a quick one.
Forgive me if I missed this, but I was just wondering about if there's been any studies on medically, MIT, taking drugs while in treatment, but also doing group therapy, cognitive behavioral skills, all that, the behavior. Those two together seem to me like, why choose just one or the other?
Yeah, like if you're specifically talking about opioid use disorder, the strongest data is for medication, but if you kind of add up all the studies, there seems to be a small benefit, additional benefit to medication, to therapy on top of medication, especially like John said, in those domains that are a little more nuanced and involve getting your life back in order rather than just staying off drugs. So basically, like medicine will get you off fentanyl, and therapy will help you get your life back.
We might have 2 more, because quick.
And we can stay. We'll stay and answer any questions you want.
And I'm just curious if you know anything about the deregulation of methadone and where that's at currently. I know there's a bunch of discussion, but I'm wondering if you have any updates about that.
No, I do. Do you?
I did just read that as part of the DOGE that they were looking at kind of incorporating deregulation into DOGE efforts currently as a way of saving costs. Now that's just total speculation at this point.
Yeah, anyone who's involved with the American Society of Addiction Medicine is one of their prime advocacy points right now, and they are trying to jump on the efficiency and deregulation bandwagon that seems to be so popular, and maybe we can get methadone out of the regulatory cage it's in right now.
And then in the front.
Hi. I have a question. The slide that you said was controversial with the 17% of the people that go into treatment, and I had a lot of my colleagues. They were up in an uproar, and I was telling them the reason why that's like that is because people go into treatment and think that's a fix-all, and then they go out and use a small amount of the drug and they relapse. I was thinking, was there a study that shows people who go into treatment, a program that uses MAT, and then they're released, what the percentage of people successful would be in that case?
Well, Sonia loves this article, but just realize too that they did talk about the fact that if you got medication as part of your inpatient treatment, you were counting the medication arm. So that is a little biased, but I'll let Sonia talk more.
Yeah, exactly right. Like I personally don't know, doesn't mean it doesn't exist, a specific study on inpatient treatment, then followed by medication, especially a high quality trial. Most of those just counted as medication. They don't talk about the setting it started in, or if they do, it's very, very short term. It's like if you start in rehab, they look at your 30-day outcome. But you're exactly right. The big risk for going to inpatient is loss of tolerance, and it's the same with being incarcerated and being released from incarceration. You have loss of tolerance. You use because you didn't gain any skills that you can transfer to your home setting, and you die from overdose.
We have one right front here. This is actually great because we're going to have staggered lunch, so it's going to delay.
This will help everyone who's not going to have to wait in line. But we are not hurt if anybody is hungry. This was a marathon talk, so if you need to leave, we understand.
So I thought your nicotine slide was very compelling, and it says nicotine and not necessarily cigarette smoking. Can you talk about the health risks for vaping and using nicotine packets or dip or smokeless tobacco and how that compares?
Yeah, that's a great question, and I think that's a big question mark right now, to be honest with you. Vaping is a relatively new trend, right? So we don't have long-term outcome studies. We do have shorter-term studies showing that it is the lesser of the two vices by far. And it's actually interesting in terms of public perception because there is data that the public actually perceive vaping much more dangerous than it actually is as compared to other things. And I think a lot of that's due to some of those kind of news articles about people having kind of vaping-associated lung injury and hospitalization, although that was mostly THC vapes, I think in Florida. But I think that's a big question as we move forward. We do know that people can use a vape as a method of smoking cessation and to stop smoking, and we think it's probably better, but we'll have to see with time.
Okay.
I can't think anything worse than combustible tobacco, though, in terms of health outcomes.
We will do one more, and then both Sonia and John are on different panels this afternoon, so we'll have some extra question times as well.
My question is about the shot. I always pronounce it wrong, Buterol. My brother was put on it. He don't have mental health issues. He just has opiate and other drug issues. But when he was put on it, it caused him to quit smoking. He didn't want to eat candy no more. Started changing his whole mind frame to the better, to where he wasn't using. He stayed clean. But my question about it is, I could see, since it being my brother, knowing him so well, the personality change that was happening, but it was for the better. If you have somebody that has a mental health issue like psychosis, anything like that, and they got put on that medication, and you're seeing a reaction in somebody with not mental health, what could happen in that situation?
That's a great question. It's really complicated, right? So there's very few studies about this medication, right? The all industry funded studies of shorter duration, very controlled environment for Vivitrol. I have not seen any data about discontinuation due to mental health effects. I'll tell you the number one reason people probably discontinue the medication is because of, it causes a lot of irritation and local site reaction from the injection. It's relatively painful in many patients, but I have not seen anything about mental health. Have you?
Yeah, I haven't seen anything about psychosis specifically and interacting with that axis. I think it can make people feel a little bit depressed. And like your brother experienced, actually, naltrexone is a key component in weight loss medications as well. It just reduces desire for a lot of compulsive behaviors. Works for alcohol. You said it worked for him for smoking. Can work for methamphetamine use. Works for compulsive eating. But it blocks that pleasure reward circuit a little bit. So some people find themselves a little more depressed on it. That's the mental health side effect I see, but I've never seen any severe mental health side effects or concerns.
You want a closing statement?
No, I just wanted to say thank you, a very good presentation, and especially the contingency management. I was just talking to my coworker. I have a daughter that's whatever, and she's working, but I think she's still using, still drinking. I don't know what her drug of choice is. But after listening to the contingency management, I'm thinking the working is what's driving her, even though she's still using, it's not anywhere where it was, but just maintaining a job, being able to pay bills. She actually sent me some money. I'm raising her 2 children. And so you have me thinking differently about, because I'm like, okay, you need to be working on just you, all this work, but that could be her contingency management. So I want to say thank you.
Well, you're welcome, and I'm glad your daughter's doing okay. And yes, the contingency management replaces that dopamine that you don't have when you're in recovery. You know, you've used drugs and you kind of fried your circuits a little bit, and you need something else to bring pleasure to your life. Well, thank you guys. We'll stay up here. If anyone wants to talk to us, we'll be here.